Velkommen igjen, kjære lytter, til Mind-Body-podden. I dag så har vi en ekstra herlig liten snack til dere innenfor smertefeltet. Vi har fått besøk av Steven og Katja, og av den grunn så kommer jeg nå til å bytte til engelsk. Dear Steven, dear Katja, dear Silje, welcome to the Mind-Body-pod. Steven Linton, you are a professor emeriti of Örebro University, and your focus has been in psychology and chronic pain. And Katja Boersma, you're a current professor of psychology at Örebro University, and your focus has also been on chronic pain. And Silje, you are my dear friend and colleague, and you're well known to our audience, so you're also a professor of health psychology here at the University of Oslo. And I'm Henrik. I'm an associate professor of health psychology at the University of Oslo. So I'm trying to scramble my way up to get to be on the level of these guys. But I get to talk to them, and that's the pleasure of having you all in studio today. So I would like to start with just asking both Katja and Steven, who are very well known in the field of pain. And I'll start with you, Steven. You've worked with this your whole life, and how did you become interested in chronic pain on the offset when you started this journey?
Well, I was studying psychology in the United States, and I was working to support myself by being an orderly at an orthopedic clinic or hospital. And I was fascinated by two men who came in the same day, had the same surgery on their back for a herniated disc. And the one guy, when I came into his room, I started at 3 o'clock. He was operated on at 10. He was dressed in the bathroom brushing his teeth. And the other guy put his light on to call me about every 5 minutes, every time he wanted to move in bed. And it's like, why is there such a difference? It's the same problem. It's the same surgery. One is up brushing her teeth and the other one needs help just to move a little bit in bed. So it really got me interested in why that might be. And in studying psychology, I thought that was a really good application of psychological learning mechanisms to why that might be.
Super cool. Thank you for that. What about you, Katja? How did you become interested in chronic pain?
Well, actually, I started off being interested in totally different aspects of psychology. I was interested. I did work in prisons with inmates and their background, their familial background, attachment, and so on, and cross-cultural psychology. So I had a focus totally somewhere different. Honestly, I think up until the latter part of my studies, I never really put any focus on health psychology at large at all. But then I got an opportunity to do an internship, my last one from my studies in medical psychology department, and that's what my interest started. And after my studies were done, I got a job at a rehabilitation center for work rehabilitation for chronic pain patients. So that's where I really got in contact with the field and understood, all the complexities and questions. And then actually it was Steven that really pulled me into the field because I'm from the Netherlands and I wanted to move to Sweden and I contacted Steven because I had read an article from him during my work in pain rehabilitation, just as a young clinical psychologist working clinically. And I saw the email that I contacted Steven and he said, well, why don't you come over and have lunch? So the first time I ever visited Sweden at all was the same time when I met Steven for the first time to have lunch with him. Wow. And a couple of months later, this is true, I had my little truck and I moved to Sweden and started working for Steven. So cool. it's really because of Steven's interests in the field that really pulled me into it, honestly.
That's so cool. And what a serendipitous lunch. What did you guys have?
Yes, it was a really plain hospital lunch, honestly. And I was totally surprised because from the Netherlands you eat bread during lunch and there were all these people having these full meals.
Exactly, in Sweden,
I'm like, what am I going to eat here?
Thank you for that. That's super cool to hear. Silje, you wanna engage the audience, and why did you become interested in chronic pain?
So I got interested because I experienced when I treated my first patient as a young student that the patient when the anxiety left. The pain was alleviated. So I saw already then the connection between the sort of the mind and the body, and got really interested. And luckily there was a really good group for stress and pain research in Bergen, where I studied at the time. So that's how I got pulled in. And I actually met Steven via Boston, which is kind of also peculiar because I was doing my postdoc in Boston and working there with my great mentor, Bill Shaw, who on the project that I was working on, Steven was a collaborator. And we went from Boston to Sweden, to Örebro, and that's when I really met Steven for the first time. And also the rest of the group, I think. I think I met Katja as well at that time. So, yeah,
I remember that.
Yeah, it's so great to hear. And of course, I was, as always, brought in by collaborating with Silje into your lovely environment in Örebro. But actually, my own experience in chronic pain stems from having chronic pain in my knee and experiencing fear and avoidance firsthand, because I thought I was healed. I was a soccer player, and I had a horrible accident on the soccer field. And I got a surgery. I'm saying soccer. You know, it's called football in Scandinavia. But I hurt my knee, and I thought I got the surgery, and I got a ACL tear and a meniscus tear, and everything got fixed. And then when I was trying to play a game again, it was this uncharacteristically fear that gripped me, that I didn't want to go into hard tackles. And that was sort of my style of playing. So I was quite limited, and actually more in danger of hurting myself, because I was pulling out almost microscopically in all these tackles. And that led me to become interested in the psychology of pain. And I just then got more and more interested in this concept of fear and avoidance. So we broached a little bit about why psychology is important for pain, but I think we should spend some time on this fear and avoidance model, because for many people, especially you, Steven, are very well known for this model of how psychology and fear can give disuse syndrome, or give patients problems when they experience chronic pain. And I would like to delve a little bit into that, because I know you also, Katja, you're very done a lot of great work on this. But what is the story behind this model, and why did you and Johan Fly in many years ago propose this model as a framework for understanding pain?
Yeah, I think that since the 70s, when learning and psychology got to be a real part of chronic pain theoretical basis, was already known then that avoidance is one of the mechanisms, one of the learning mechanisms, and Fordyce and others talked about it. But the model with fear avoidance developed more because that you could see the snowballing effect of it, that if you start avoiding something that you're afraid of. And let's face it, pain is a very threatening thing, and it has immediate consequences that are very powerful. And so it's relatively easy to start reacting to this and to try to avoid that. Anybody would, because you don't want to get hurt. You are avoiding with your knee because you don't want to hurt your knee further. But once it starts, it's so difficult to come back to the situation and see that, oh, I can use my knee, and it's not going to be a problem. So you start avoiding, and then worry starts developing, or could start developing, which snowballs into that you start avoiding more things, and it starts generalizing. And once we start avoiding things, then we also lose, if you will, the positive reinforcement of being with people, because we're restricting our social activities. It starts restricting our pleasurable things that we do, going for a walk and so on, going to the movies and sitting. And that in turn makes us more susceptible to feeling the pain. So our focus on the pain, how we interpret the pain, all can be influenced by this, and it starts snowballing. And when the snowball starts rolling, it can be very difficult to stop it. And it seemed to me, and not least to Johan, who is sort of the founder of the theory, that this is very important for not everyone, but many people who develop chronic disabling pain.
Katja, you've worked with this for many years as well. I know you guys have started a new perspective now, but I want to stay with the historical model a little bit, because you once taught me how to engage in a fear hierarchy and how to expose people within the hierarchy. Yeah. And that stemmed, you said, from work that's been done in the Netherlands and with Steven. Do you want to share a little bit about your thoughts about this snowballing and how you see this process evolving in patients?
Tying back to where you started with your personal experience, I think that's a really excellent example of how subtle fear is, and how much fear is not about like some conscious experience of the emotion of fear as we all know it when we think about being afraid of I don't know, spiders, or you feel your heart palpitating and you're sweating and so on. That kind of experience is not really always, it's most of the time not what it's about. So it's more like kind of almost like an automatic protective urge or drive, motivational drive, as they say, that is very subtle and actually I think going to yourself and to your observing yourself is sometimes the best way to find out like where these subtleties are. So so when I started working with Steven, I also we started with the fear avoidance model, trying to translate it to treatment, because one thing is about identifying that people are afraid or have some kind of protection or overprotection that is kind of keeping them from being able to do what they want, or like you were describing, is making movement actually more dysfunctional or not as free and actually is probably not so good for the body, just to to brace and to be careful. So we knew that that was identified, but then to try and translate that to how to help people get over that, especially if maybe people are not so aware that they are afraid, because the experience is one of being that this might cause injury or cause pain, right? So that's all connected to one another. So when I started, Johan Vlaien and his group at Maastricht University had developed a kind of a translation of exposure therapy, which is known, well known in for anxieties or fears. For example, for spiders, you gradually expose yourself to what you're afraid of if it's heights or something like that. So that therapy model was translated to be applied to movements and activities. So actually this was in the beginning of the year of the 2000s, I think 2001 or something like that. I went to the Netherlands to observe how they were doing that. And what they used was a very practical method of helping people get in contact with their protective responses and their fears, if you so will, by showing them pictures of everyday activities, like maybe 90 or 100 pictures of people biking, walking in the woods, maybe jumping off a little height, carrying a basket of laundry, reaching for a cup in a cupboard, etc., etc. So just really, really normal movements and activities. And they use that to ask people, so what if we would ask you to do this right near here and right now? What would your response be? And on the basis of those responses, you could create like what you can call a hierarchy. Some things, just no problem, I could do that here and now, wouldn't faze me. And others, like, this would never be possible. This would really, I don't know what would happen, but it's not possible. So that would be like 100 if you would, put it on a hierarchy, like a temperature meter from 0, nothing, to 100, just impossible. So these pictures would then end up on this thermometer of things that are possible and things that are not possible. And on the basis of that, we would start at a reasonable level of problems, of if you so will, fears of protection, and ask people to do it. Or ask people, so let's do this. let's reach for this cup in a cupboard, or let's lift this box. What do you think would happen? And then we would do it and then evaluate whether people's, expectations were as they thought, or whether it maybe wasn't as bad as they thought. So that is the basis of the treatment, I would say, of exposure treatment that Johan Flein and his group developed, and then we started to test in our lab as well. And you can think of it as that we would start with very simple twisting and turning, moving the back, if we're talking about back pain, to maybe in the end, playing soccer, maybe even being the goalkeeper as a soccer player and catching balls in the air and landing on a mat or something like that. Just things that many people would never think would be possible. So it's just obviously not where you would start, but that could be the end result of the exposure treatment.
Yeah. And I just want to add to that, when I do this with patients, it's actually a journey just looking at these photos and actually realizing how totally unacceptable a movement might be. I've never done this with a patient without the experience of them saying, wow, I really didn't think I was that uncomfortable with doing that.
That's right. Yeah.
And I have to put that on the top of the hierarchy.
Yeah. And that's what you were saying. It's you don't know this. It's not. It's because it's not so verbalized, or not. It's not so conscious.
Yeah, exactly.
And it's not so attached to a real fear experience, unless you would expose people to these things right away. That then I've seen several times that people would actually feel like their heart starting to beat, starting to increase, and getting some sweaty palms and so on. But otherwise, I think the experience is a different one. Yeah,
absolutely, and they may not mentalize the concept of avoidance, but they say, "I just won't do that."
No, I wouldn't do that.
I wouldn't do that.
No. Yeah. That's right.
And I think that's important because most patients, if you ask them, "Are you afraid to do things?" they don't conceptualize it that way. It's like, of course I wouldn't do that. It's going to hurt, and I might injure myself. So why would I do that?
Exactly.
Which is
I'm
normal.
not afraid of it. It's just not a good idea.
No.
Yeah. So our conceptualization theoretically from a sort of learning is different than a person that has the pain.
Yeah. And I also think that the fear avoidance model has developed throughout the years to adopt a little bit of different terminology than the fear concept, more towards the threat value of pain, even though that's quite a formalized concept, but protection or an overprotection or something like that.
That's such an important point that you guys bring up, because me and Silje, we talk a lot about this, that in Norwegian culture and context, the word fear translated from English does not apply to these patients. They don't like it. They react aversively when you say you're afraid of this or that. Yeah. And actually, when you talk about this, Katja and Steven, I think about what you're saying about I should frame this model actually using different words with my patients, because when I talk about fear and avoidance, I lose them a little bit in the education part.
Yeah. That's actually one of the, I think I would say, one of the main things that we learned throughout our journey with testing this treatment model and refining it. And like you said, we're going to talk about this later, but where are we now? Yeah. I think one of the main things that we realize is that if we want to have people, adopt this view, looking at their inabilities to do things from this perspective, then we have to change the way we talk about it. Yeah,
absolutely. Yeah, I think that's a nice segue actually to your current large actually project of disseminating a revised or expanded form of the fear avoidance framework into the clinic. And that's part of the reason why you're in Oslo now, but also part of the reason why me and Silje have gotten to know this model perhaps even better than we thought we did, because it's like with the Norwegian playwright Henrik and Per Gynt. It says, think about something, say something. Yeah, that's completely different than actually doing something. When you actually do it, you get another feel for the model. And Silje, would you like to maybe introduce this new project that Steven and Katja has been doing, because you've been spearheading it here in Norway? What caught your eye about this, and what kind of reflections did you do when you first saw this beautiful name, the hybrid treatment?
The hybrid. So I started talking to Katja and Steven about this in Sweden, actually, when I was at the conference there, and and learned about this model that they had developed that made a lot of sense, both scientifically but also clinically, because the hybrid is the hybrid between two sort of elements, and I'll let the architects explain it themselves. But basically, from sort of a clinician perspective, it's about exposure coupled with emotion regulation. And we know that exposure is important and is part of the recovery process. But for many good reasons, it's very difficult to expose people. And many people have sort of resistance or struggle with the exposure part for many good reasons. And to sort of get in position or to help people succeed with the exposure, emotion regulation is really, really important. And this treatment really sort of perfection these two sort of elements. And we've been lucky enough to be the clinicians in this project and have a small sort of satellite in Norway. It's a dissemination project, which means that you have already tested it in a trial and shown that it is effective. And now it's time to sort of see if it works in clinical practice. And we are one of those practice sites. So it's been a really good experience to learn it and to try it and to test it out. And to see, particularly with those patients that we might not succeed as much with, those who have very high both pain but also very high emotional distress, a lot of anxiety and depression. In those patients, they seem to respond really well to this model because we have the sort of the emotion regulation element, which means we help them deal and handle and cope with their emotions very effectively.
Yeah, and that's a great segue, Silje, into you guys sort of framing what was the grand idea behind this, because you were explicit to us that you wanted us to pick the not the worst patient, that's a horrible expression, but patients who are exceedingly difficult to get to alter behavior because they have a lot of boundaries within themselves and in their psychology in the way of exposure. So what was the grand idea? When did you see this hybrid model for the first time?
If we go back in time, we were working with the fear avoidance model and this exposure therapy, and it was working pretty well. But we did notice that about a third of the patients just did not get better. And as clinicians, we were sometimes quite frustrated that it was hard to engage the patients. They just seemed to be so afraid that they weren't able to really do the hierarchy the way that we had planned. And one of our colleagues, Ida Flink, did a study and looked at the relationship between variables that you would think would make treatment easier, like if you have high levels of fear, high levels of catastrophizing, you'd think that would be people who have a lot of room to improve, so they might get the best results. But in fact, when we looked at the study, and Ida wrote this paper on this, it was exactly the opposite. And that turned us into the idea that maybe they're not able to regulate their emotions. And we started looking at the literature, as Silje was saying, and most of the patients we had in that category also had depression, anxiety, etc., emotional distress, if you will. About the same time, we developed a relationship with Alan Frasetti, who is a dialectical behavior therapist, and we started looking at emotion regulation and those kinds of things and his way of working with really difficult patients, and thought, well, wow, that could be a really great combination to have exposure as we've been conceptualizing it, but adding this emotion regulation aspect to it. It just seemed to make it so much more human, so much more acceptable, so much more powerful.
That's how I remember it as well. I think it's interesting if you think about like how do you come up with new ideas? Like what is the process behind that? If you start to map that, and it's kind of a circular movement going through intervention, development, evaluation, and so on. So when we did the exposure treatment studies, we started with single case studies, single case experimental designs. Then we did an RCT. Then actually, when we did that, we saw that we were on average good results, but then we already had the clinical experience that, but this is not working for everybody. We tried to isolate what is not working. So it was kind of a lot of, discussion work, and also with the other groups and so on around that. And by that time, we also wrote a book on exposure therapy together with the group in the Netherlands. Actually, also maybe, if you think some things just kind of happen, is we were asked specifically to write a chapter on obstacles in treatment. So that forced us actually to try and pin down like elements. So that, and then in combination with, this other lines of research we were doing, looking at, also predictors of treatment outcome in general, observational studies looking at subgroups, that all kind of keyed into that there's on the one hand is how do you conceptualize and get people on board in treatment when it comes to this concept of fear and avoidance, and the other is that fear and avoidance is not in it does not exist in isolation. It's contextualized in people's lives, and some people have a lot of problems, a lot of emotional distress and other problems. So we're feeling that we weren't able to address the whole person in a way. So those were I think the two elements that we extracted. It's just this communication and getting people on board to do this treatment, as well as being able to cover the problems in a kind of a or holistic way, if you so will. So, and then Ellen Frasetti came along, and he, the DBT model, the dialectical behavior therapy, is originally developed for severe emotional dysregulation problems, summarized in personality disorders, formerly called borderline, now emotional, I don't remember what it's called, but it's a different name to it now. Anyway, so that is also a model of people who have a lot of ways into healthcare, who have a lot of different problems. There's always a question, what is their primary problem? What's the secondary problem? What comes first? What should be treated? So in that, for that problem area that DBT was originally developed for, I thought there were a lot of similarities to what we're struggling with when we're trying to help people who suffer from chronic pain, is that not knowing how to conceptualize the whole problem and also not knowing how to address it in a coherent way.
Yeah.
So and also problems with people feeling that they're not being understood, that the people feel invalidated and leave treatment. That's also I think a central element. So the theory of what Ellen Frasetti brought to our clinic was really kind of filling some gaps that we thought were necessary.
Yeah.
So then you started to design something together with him. Right.
And interesting scientific caveat in this is that there was a lot of discussion in our own group, but we also discussed with others at conferences and these things. I think this is so valuable because it wasn't that everyone jumped and said, oh, wow, this is a good solution.
No.
Many of the people said, well, you're just not doing it right. And if you take a hierarchy right and you do this, they'll come around. And if you need 15 sessions, do 15 sessions. If you need 30, do 30. But the thing, as you're pointing out, is that you can't engage somebody for 30 sessions of this traumatic, in a sense, fearful exposure if they're not engaged and willing to do it and see some progression. So it was a new idea, and I think that it's interesting to see how these ideas develop. And as Katja was saying, we started with some case studies, some systematic case studies, and looked, can this be something? And work from there.
Yeah. So the good thing is that you see this circle, right? You see, even there we started with case studies, and then we did an RCT, and now we have a third project with the implementation that you guys are a part of that we're very happy about. But also there, I think now coming towards like kind of the end of the circle, I think there's a new round of asking questions like, okay, is this working? So I really want to like just stress this as that for us this is not the end of the journey of trying to develop treatments because it's very complex for sure. Yeah.
Yeah, I think that's why your group commands so much respect. And I know you're very humble and you don't toot your own horn, so to speak. But I think in every walk of pain and science and these international conferences, your group always commands a lot of respect. And I think that's because you also come from the heart. You do this with patience. It's not a theoretical exercise. You actually try stuff with people and see how they respond to that. And I think that's something that I had to, in my journey as a scientist, learn to respect in a way, because there's so much focus on neuroscience and so much focus on behavioral genetics and epidemiology and big data and everything, and then this is kind of messy. It doesn't align with these positivistic ideals of hypothesis testing and then you're right or you're wrong. It's more like, well, maybe it's right for some people and wrong for others. So I think it's incredibly valuable that you get to that we get to hear what you think about and how you come up with this notion, because it's incredibly important. And I think you mentioned it briefly, but validation and dialectics. Can you explain that a little bit about that? Because dialectics is very powerful. But it's also a little bit fuzzy. What does that mean with the dialectics for us people who not study language or academics? It's a weird concept. Yeah. And validation. What do you mean about validation? Yeah.
Well, how about if I take dialectics and you take validation, Katja? Dialectics has to do with the idea, which is a little bit philosophical, as you are saying, that one and the same thing can be both seen as something really good, but it can also be seen as something that's not very good. So one of the classic examples is your 4-year-old child comes home from school and has done a painting for daddy and shows you this painting, and it's absolutely wonderful. At the same time, you wonder, what is it? So, in one case,
I actually framed it.
Yeah. So, on the one hand, you could say this is not a very good painting. On the other hand, you can say this is absolutely wonderful because she's expressing something. She's done it for daddy. And so, dialectics has to do with being able to see things from different perspectives and being able to see that in most things there's something good about it, but there can also be some things that are not so good about it. And sometimes we need to have this dialectic to be able to move forward.
And just to push a little bit on that, Steven, how would you apply that to a patient who is afraid to expose him or herself to a painful experience that reminds them of a traumatic injury or something? Can you try to frame it in that context?
Yeah. So early on, when I'm working with a patient, I would be talking about that we will want to look at things a little dialectically and give some examples and so on, so they can understand what we're talking about. And then I would say that, sometimes we might come to a point and we might want to do something that is exactly the opposite from what you feel like you would like to do. So instead of going to the left, I might ask you just to see what would happen and to see if there's something in it. Let's try going to the right and see what would happen. And we use a lot of examples. We say sometimes if you're at work and there's somebody who's really obstinate and you're not getting along with them, if you just sit down and say, well, let's have a chat about this, rather than pushing back and saying you're wrong. I want to listen. Let's try what you want to do, Henrik, and we'll see if that works. And it can make a big difference in your relationship. And so people understand these examples. So it's the same with your 4-year-old that comes home and throws the things on the floor. You could get very angry, and that's one way to try to get your child's behavior to change. But you might also do something like, oh, it's so wonderful that you're home. I'm really glad to see you. How about if we hang up your coat and put your shoes over here? Maybe that's going to send a message. Maybe your daughter will learn that that's what you're supposed to do. So we can sometimes do things that are the opposite of what we impulsively feel that can be very helpful.
It's a beautiful example, Steven. Thank you. And in this there's a lot of validation, because when I do this with patients, I kind of get eager for them to catch it, to understand the concept of dialectics. And then I push too much, and then they don't come back. And that's because I don't validate their experience
I
think.
Yeah, so in the end, I think validation and dialectics go into one another, right? So just one more word on dialectics, because I think that it bridges to validation, is I think one of the reasons that we thought that the dialectical stance or the dialectical philosophy as a basis for the therapy would be helpful is this, that you feel that you see that patients get stuck in a corner of a dimension when there's another opposite.
Exactly.
And we want to go to the opposite. So people avoid, we want them to approach. So that's one of the, I think, like one of the central ones. But there's way more than that. And so the dialectical stance is really a philosophy about that most everything that we do has an opposite. And it's not about identifying what is the right side of, the corner, which corner is the correct corner, but it's about being flexible and being able to move on the dimension from the left to the right, etc. So that's kind of the basic. And so if you can get people to embrace that idea, then you're not on opposite sides anymore. Like you're saying, let me just tell you what the other corner will be able to give you, and you'll understand that that's where you need to go. So I think that's validating to understand that there's no right and wrong. The avoidance is not wrong. It depends on the context. And I think so. The problem with emotions and motion regulation is not that there is one right way to do it, but it's more that people have become inflexible and stuck in one way of approaching protecting themselves. But protection is an extremely important corner to be in. So I think validation is about like having people understand that whatever approach they've taken to solve their problems or to deal with their problems is totally understandable. But there's another corner in the room that if you dare to explore it, might be able to give you something. So the validation perspective is the way to address people and their way of doing and viewing things in order to be able to explore dialectics in behaving and handling problems.
And I think the basis of validation is understanding the person and sort of walking in their shoes, if you will. It doesn't mean you agree with them. It doesn't mean you feel sorry for them. It just means that I understand that in your situation, in your context, you experience this in this way. So we use a lot of phrasing like anybody would react like you did, Henrik, when your knee is hurt. Of course, you're going to be a little concerned about what's going to happen when you come back on the playing field. Anybody would. It's very understandable. Doesn't mean that that's where we want to go. We might want to go to that other corner, but it means that I understand this. So then we have a basis. We sort of connect, and we have this shared understanding that people talk about in healthcare situations. And I think it's very, very important, and we learned that is so valuable as a basis if you're going to introduce exposure.
Yeah, Silje.
I think also that's one of the biggest sort of eye-opener for us or for me in participating in this project, because I think that for many patients it can be a very it's kind of a cognitive dissonance that you're as a therapist we're seeing how they struggle and what they're avoiding, and we're asking them to do stuff, and at the same time they're in this excruciating pain, and there's a reason why they're avoiding it, and we're still pushing it or encouraging it. And so in order to help that happen, I think validation is a very powerful approach. And at some level we've always done this because it's about empathy and understanding the patient, but it's a new world opening up with all these different levels of validation.
Yeah.
There's different both nonverbal and different conceptualizations and different ways of doing it that gives us so much more it's such a broader approach.
It is.
And more tools that we
There's
can
more
use.
depth to it than you would think if you would just, because I think many times, I mean, in psychology, obviously, a lot of skills training in communication and, validation, or the more basic levels of validation, being able to, understand another person and be able to communicate that's part of it, but it goes deeper than that. I feel that if you look at how they've theorized about this, and I think the purpose is also a different one, because sometimes I feel that on a simpler level of validation, that we're really out after getting people to do what we think is good for them, so that we don't, we're trying to reduce their resistance, if you so will. But I think in dialectical behavior therapy, validation in itself is the intervention. And you kind of rely on that people, once they feel understood, will be able to choose action or act in more flexible ways just by themselves. They don't need so many instructions on which corner there is to choose. People know this themselves. So the solution is usually in people themselves. It's just that they're locked and stuck and defending themselves against what they feel that other people are asking of them.
So their self-efficacy and problem-solving can come forward.
And
I think it's also important because it offers an opportunity for us who are working with clients or patients to be very honest. So if you understand the person, I understand, Silje, that this is the way it is and you feel like you can't do these things. But I can honestly say, and, I'm concerned, where is this going to lead you? If you're not able to go back to work and you're as young as you are, how do you see your life unfolding? And that's a very honest question. It's a little bit threatening, but I think if you have a good relationship and you've been validating and so on, you can raise that, as we talk about in academia, critical friends and giving us feedback about teaching or whatever, that you have to be able, if you're a really good friend, you tell a friend or you ask them, you're concerned about them. So I think it's a powerful tool.
I agree. I think also I come from the past decade or so. I've been very into the whole acceptance and commitment therapy paradigm, and I think that's inherently connected. All psychological therapies are in some way connected, but it's inherently connected to this idea of flexibility, right? And this idea of moving. I spoke to Steven and Ida and you about this for many years ago, but I think one of the beautiful illustrations of that is not to bring up the whole acceptance and commitment therapy, but Stephen Hayes has a beautiful image of the pivot. He calls it when you can see the patient pivot to the other corner. And that's almost a physical thing in the session. And I think that's a beautiful way of describing what happens to someone. And you can never predict what will cause the pivot. But validation is an extremely powerful tool in that. Yes. But I think one of my greatest struggles as a therapist is the patience, both personally and clinically, in the validation, is the patience and the belief in the patient's own self-efficacy. And I think Carl Rogers also framed this very beautifully, is that giving advice and pushing people is actually a very low form of empathy. It's not very empathetic.
It's true. Yeah. So, and I think you're right. I think that's a good a reminder that this is not new, in the sense that even Carl Rogers knew this already. It's just that sometimes yeah, exactly. So, and you see it in ACT as well, and so on. So I think there's traces of this in several therapies. But we do forget about this.
Absolutely.
And
I think DBT brings a structure that's very interesting, because one of the problems that the lack of patience exerts is that you tend to go over steps in your validation because you're like, oh, that's just basic human behavior, like being able to smile at people and meet their eyes. But a lot of my young psychology students don't do this. When we practice therapy, they think they do it, but they don't actually express it in any meaningful way. And when you're in pain, you're also internal in a way. So you don't gauge people in the same way because you're focused on protection. So you should forget to see the therapist's beautiful expression of empathy sometimes.
And not experiencing that you're not being understood is almost like an existential crisis,
isn't it?
And I think we see that in so many patients and in so many stories that they don't feel understood, and that the therapist or the doctor, they don't understand how their situation is. And I think it's so crucial. And I think learning more about validation, applying it in the structured way that we do here has really opened my eyes to how significant this is. And we've even taken this concept in our long COVID trial, the treatment that Henrik and I developed, and really used you as inspiration and brought this validation aspect in to that treatment as well.
Yeah.
I think that's so important that you say that, because I was mentioning it to Steven when we were traveling here, is that I read this synthesis of qualitative studies on what it's like to live with chronic pain. And this is a synthesis of, I think, 57 separate qualitative studies. It's like it's ground covering when it comes to what is it like to live with chronic pain. And I would say one of the central themes is one of feeling isolated from other people and not feeling understood, and also in relation to other people, not feeling good enough, and not being believed, or feeling that you've lost your credibility. So I think that this is very, very central to the experience of chronic pain. And if we forget about that and we start focusing on, the details of fear and avoidance and how we expose the movements, people will just not, of course, be on board with what how we're trying to help them, even though we mean well. I think it's very important to realize that.
And I think we have a real challenge with, because people with chronic pain aren't seeing just psychologists. We're all psychologists in the room here today. But they're meeting other people in the healthcare services. And some will try to explain their pain by using the brain. The person might feel like, I'm exonerated, it's not my fault, it's the brain that's not working right. But it's not maybe a good explanation, nevertheless, that helps them move forward. And I think that Katja's comment about that some people in the medical field might want to use validation to work with resistance. And I get questions from people, well, how can I get patients to take their medications? Because they don't take them properly. And that's not, for me, that's not the main question. You need to understand, what is this medication supposed to do? Why doesn't the person want to take them? Or because it could be a whole range of things. Probably they don't believe that it helps them, or they're not experiencing any help. It could also be that they have side effects. Could be lots of reasons. Or it could simply be that they don't remember to do it, and that's fairly easily remedied. So I think we have a big challenge to spread the word and have some training for others in the healthcare system.
Absolutely.
So that we're all on board and pushing in the same, or not pushing, but we're aimed in the same direction.
I think one massive experience for me was when I did a strange thing. So I've done a lot of odd things in the clinic, but one of the things I did was I followed 5 patients over half a year, and then after half a year I said, now we're going home and see how you live and interact with your family and see how your friends, who are your friends, are you okay with that? I see where you work. And these people were we had a very strong alliance. So they were like, yes, I want to show you where I live, where I work, and because I feel like we know each other and I trust you. And that was world-breaking to see how much of a portrait they were painting for me in the session, and what was actually going on when we went to where they worked and where they lived. And I saw that they were presenting to me, they wanted me to see the best versions of themselves. And when they came out in the world, there was so many layers upon layers upon layers. And I mean that with a very strong sense of empathy for what they were experiencing. But they wanted so badly for what we were doing to work, that they were kind of showing me that it was working, but maybe it wasn't working that well that we were thinking. Because what happened, it was your side effects thing, Steven, was that with this one girl, we worked on her work-related problems, and she wasn't upping her percentage. She wasn't actually going to work. And I was like, everything is going so well, but you're not working anymore. What is happening? And that was eye-opening to just then go to her work and actually see that, well, she wasn't treated very nicely by her coworkers. They weren't respecting her pain situation at all. They were annoyed because she was on sick leave all the time and not pulling her weight, so to speak, in the workplace. And she never told me that was her experience. Shame, resentment, aggression was what she was feeling in the workplace. And of course you wouldn't want to go back to that when you're feeling better and you're actually having momentum. You don't want to go back to the place that pushes you down and makes you sick. So it was eye-opening for me.
That's very interesting that you say that. Actually, I think that's maybe something that if you think about the future, like what should we pay more attention to? That's people's like social context. And the thing is, it's interesting because if we think about young people, children, young people, then that is part and parcel of treatment. Is the parents, the family, the friends, and so we I mean, there's psychologists at least are much aware of needing to include.
They're trained in viewing the system.
But somewhere when people become adults, we kind of forget about this, or we note it and we don't pay attention to it. We try to, we do therapy in the therapist's office, and we think that we'll generalize to people's lives, and we don't know much about people's lives and how their problems are contextualized. So.
No, I thought I did, but it was eye-opening. I think not to sort of it's a tangent, but I won't go on and on about it. But I think it's just a matter of simply bringing it to what Steven's point about side effects is that when something isn't working in therapy and it's very objective, like the amount you work, then that gives you a very good perspective on you're not hitting something is not mapping with what you see in the session is not mapping what's happening in real life. That was basically the point. But I wanna bring us to the last and final aspect because I really want to hear about this. So Katja and Steven, what excites you both the most now in the field of pain psychology? Because I really want to hear it. I never get to ask you these questions. What do you think is the most exciting?
I'll let Steven talk first, and I can think about the answer for a second.
Well, I think we've had some challenges, and one of the challenges that excites me is that we seem to have treatments that work reasonably well, and like a cognitive behavioral therapy-oriented rehab is the treatment of choice, and yet there are boundaries. We're just not, the results are not on average improving that much. And so I think it's really interesting to see what can we do to go beyond that. How can we apply a theoretical basis? What is it that we're not getting here? And I mean, we have some clues. I mean, I think one of them is what's come up here, is that we need to look at the context more, having this bigger picture. We need to look at individuals more and not just applying, two sessions of relaxation, 2 sessions of this, 2 sessions of that is really tailored to the person. Another thing that excites me quite a lot is the idea of early interventions that are preventive. Can we meet this person the first time they come to healthcare with their back and see, are there things here that put them at risk for developing chronic pain? And could we, at a very early point, do something about that? And Katja and I have done some work with this and had some success, but it's a real challenge, and it's a super challenge to get that idea into healthcare systems. So I find these things quite exciting.
Yeah, I would really love to hear what you guys think about how to measure the success of such a prevention as well, because how do you measure that something doesn't occur is a challenging statistical. I think individual studies is the way to go then with that.
Well, you're absolutely right. If you're going to do an epidemiological study, and you say 10% of those with back pain develop long-term back pain, then you're up and you probably need 1,000 or 2 in each group. And that's that's difficult to do in Norway or Sweden or even in the United States.
But thank you for that, Sima. I think it's super good examples. What about you, Katja?
Yeah, like I'm not really in an optimistic phase of life at this moment.
Okay, then we go on to Silje.
Let's say like there's two levels to this. Like there's if I can also like turn excitement into some kind of concern, then I'm okay. Now, I think what excites me is the research being done on the interface between like experimental learning paradigms, basic neuroscience, and clinical psychology. I think these fields are merging in a way that really brings things forward. And I think about how does fear learning work in understanding the development of pain, the pain perception and spreading of pain, for example. And the work on, for example, placebo and nocebo responses. So the work that's been done there, like on a scientific level, I think is very exciting as really moving forward and bringing fields together. My concern is a little bit on the clinical applied side, is that I find that we've kind of, we're kind of spinning our wheels when it comes to treatment development, and not in the least getting them out in the clinics. So I feel that like basic knowledge on how to treat patients with chronic pain, like the basic really good treatment models that were already developed in the end of the last century, that kind of knowledge, like for example, the work that Fordyce did, et cetera, the applied operant learning models, that kind of knowledge I see is kind of dissipating a little bit, the pressure on psychologists in clinical reality is high. So people are supposed to do a lot with less and less time. We're trying to put things online digitally and think that will improve outcomes for people. And I'm not so sure about that. So that worries me, so that the quality of care delivered is becoming less, and that we're actually losing the knowledge in reality, even though we have them on paper or digitally stored in lots of scientific output. So that there's, I feel that the gap is kind of quite large between clinical reality and what we know. Yeah, that's not a very positive note, but that's what worries me sometimes.
But I think it's an interesting one, because we're talking about validation, and so you conjure up this image that you're sitting in the same room, or at least you have a person that's on one end of Zoom and you're on the other, so you have this conversation and you can validate them and you can listen to their story and you can really get into their shoes and get these contextual things. But at least in Sweden at the moment, there aren't very many clinical psychologists that get the opportunity to take that much time to actually do the basic assessment that we all probably think you should do. So it's concerning.
Yeah, and I mean, rehabilitation centers are closing, et cetera. So there's because there's a shortage of money and things like that. So
but that's also fascinating on a whole new level. Why economists are always complaining about a shortage of money? They will never say that now we have enough money
to
we can actually
develop.
treat people. But okay, I see that we're drawing to a close. So Silje, let's you and me talk about what excites us. It's a lot of things. One of the things that excites us the most is the treatment you developed. We think it's both elegant and effective. And speaking on a personal level, it's been eye-opening for me to actually do this. And I think that's what I would take from this. And what your concern is, Katja, is you have this scientific knowledge, but the applied knowledge is a far cry from reading in a paper. You have to experience it and you have to learn from that experience. So being mindful of our time together, thank you so much for sharing your knowledge and your insight. And we're happy to have you. We're honored to have you. And this has been a great episode, so I think, if I should note it personally. So if you like it, dear listener, please share with your friends and family and who you think will enjoy this experience. And thank you guys so much for listening, and we'll see you next time on the Mind Body podcast.